Hi there, my name is Shannon, and I am here to share with you guys about my capstone project. And we are going to be talking today about dementia and the COPE program, which is my final project. So just let me get this going for you here. Okay, so welcome. My name is Shannon Beedy. I am a capstone student at Huntington University, and I am working with Monica at Oakwood Creative Care, and the focus is on dementia and the COPE program. So we'll be talking about that today. And the reason I chose to create this CEU course was because as a student developing my capstone, we had not really covered geriatrics prior to choosing a topic. And this made me feel overwhelmed because I have a passion for working with older adults, but I felt like I just didn't know enough. So I worked with my teachers to find outside courses and mentors to talk to regarding dementia care, and was able to develop my project by networking. My hope is to inform future OTs and encourage the role of OT in dementia care. So I think it's really important. I think we have an amazing role here, and that's what we're going to highlight today. So first, every 3 seconds, an individual is diagnosed with dementia. Over 40 million people worldwide are living with this chronic terminal condition. The number is expected to increase to 75 million in 2030 and 132 million by 2050. Over 16 million families in the United States provide support and long-term care to persons living with dementia. In addition to Alzheimer's dementia, there are other types of dementia that also contribute to this overall prevalence and morbidity related to dementia in the United States. These include vascular dementia, Lewy body dementia, frontotemporal dementia, and a few others. The morbidity related to dementia is significant, and it can have a profound impact on the quality of life affected by those living with it. Dementia can cause cognitive impairments, memory loss, behavioral symptoms such as agitation and aggression, and physical decline. It can also lead to increased healthcare utilization, caregiver burden, and social isolation. So the objectives of this presentation is to define dementia, including key characteristics, going into caregiver burden and the growing problem we're dealing with in our nation, and more specifically in Arizona. We're next going to identify opportunities to address this growing problem and use the COPE program. We'll identify key benefits and outcome to the implementation of the COPE program. I will explain occupational therapy's unique role in the implementation of the COPE program. And then looking ahead, I'll explain how to join the dementia team, become COPE certified, and support underserved communities in Arizona. So when we're looking at dementia, there are 2 doctors here in Arizona, Dr. Anna Burke and Dr. Jerry Hall. They both work at the Barrows Neurological Institute. And they came up with an umbrella term. So dementia is describing a broad category of symptoms indicating there is an illness damaging the brain. It is not a specific diagnosis. The term simply indicates that there are changes in thinking, so cognitive changes, that are affecting a person's ability to function as they did before. So that's why it's really important for us to understand the overall arching identification of what memory changes look like and cognitive changes look like. So we're going to look at key characteristics for early detection. It is important to identify early stages of cognitive signs versus normal age-related changes. So we're going to go through those together. So the first one is memory loss that disrupts daily life. So one of the most common signs of Alzheimer's disease, especially in the early stages, is forgetting recently learned information. Others include forgetting important dates or events, asking the same question over and over, and increasingly needing to rely on memory aids. So things like reminder notes or electronic devices, or perhaps a family member that helps you log things and get to appointments. So the typical age-related change is sometimes forgetting names or appointments, but then you remember them later. The next one is challenges in planning or solving problems. So this is a big one. Some people living with dementia may experience changes in their ability to develop and follow a plan or work with numbers. They may have trouble following a familiar recipe or keeping track of monthly bills. They may have difficulty concentrating and take longer on things that they normally didn't take long on before. So initiation is part of that. And what's typical? Making occasional errors when managing finances and household bills. So trying to problem solve can be one of our big indicators. And then difficulty completing familiar tasks. So people with Alzheimer's often find it hard to complete daily tasks. Sometimes they may have trouble driving to familiar locations, organizing a grocery list, or remembering the rules to a favorite game. A typical age-related change would be more like occasionally needing help to use a microwave setting or to record a TV show. The next one is confusion with time or place. So people living with Alzheimer's can lose track of dates, seasons, and the passage of time. They may have trouble understanding something if it is not happening immediately. Sometimes they may forget where they are or how they got there. So a typical age-related change would perhaps be getting confused about the day of the week, but then figuring it out later. And then the next one is trouble understanding spatial, visual images and spatial relations. So for some people, having vision problems is a sign of Alzheimer's. This may lead to difficulty with balance or trouble reading. They may also have problems judging distance and determining color or contrast, causing issues with driving. So a typical age-related change would be vision changes related to cataracts or aging of the eye, presbyopia. The next one is new problems with words and speaking or writing. So people living with Alzheimer's may have trouble following or joining a conversation. They may stop in the middle of a conversation and have no idea how to continue, or they may repeat themselves. They may struggle with vocabulary, have trouble naming a familiar object, or use the wrong name, so calling a watch a hand clock. Typical age-related changes would be sometimes having trouble finding the right words, so that it's on the tip of your tongue situation. Next one, misplacing things and losing the ability to retrace steps. So a person living with Alzheimer's disease may put things in unusual places. They may lose things or be unable to go back over their steps to find them again. He or she may accuse others of stealing, especially as the disease progresses. So typical age-related changes would include misplacing things from time to time and retracing steps to find them. So usually you find them. The next one is decreased and or poor judgment. So individuals may experience changes in judgment or decision-making. For example, they may use poor judgment when dealing with money or paying less attention to grooming or keeping themselves clean. So when you're looking at the typical age-related change, making a bad decision or mistake once in a while, like neglecting to change the oil in the car, is normal. Next, we would see withdrawal from work or social engagements. So a person living with Alzheimer's disease may experience challenges in the ability to hold or follow a conversation. As a result, he or she may withdraw from hobbies, social activities, or other engagements. They may also have trouble keeping up with a favorite team or activity. So a typical age-related change would be sometimes feeling uninterested in family or social obligations. And next, we have changes in mood or personality. So individuals living with Alzheimer's may experience mood and personality changes. They can become upset, confused, suspicious, depressed, fearful, or anxious. They may be easily upset at home with friends or when they're out of their comfort zone. The typical age-related change would be developing very specific ways of doing things and becoming irritable when a routine is disrupted. So we all don't like it when we get out of our routines. So we are in Arizona here, so we're going to talk a little bit about Arizona statistics from the Alzheimer's Association. So currently we do have 150,000 people over the age of 65 living with Alzheimer's dementia in Arizona. 8.9% of those people aged 45 and older are currently showing cognitive decline. 260,000 familial caregivers bear the burden of the disease in Arizona. 511 million hours of unpaid care are provided by Alzheimer's caregivers. 10.8 billion is the value of that unpaid care. 414 million is the cost of Alzheimer's to the state Medicaid program. So we're looking at some pretty significant numbers here that are just increasing as we go. And then when we're looking at the high costs and effects of caregiving, the estimated number of caregivers for people with Alzheimer's and other dementias is roughly 11.2 million. Caregivers provide 18 billion hours of unpaid care in 2022, valued at about $340 billion to persons living with Alzheimer's and other dementia. 2/3 of these caregivers are women. The prevalence of dementia and depression is higher among dementia caregivers, 30 to 40%, than other caregivers, such as those who provide help to individuals with schizophrenia, 20%, or stroke, 19%. So why COPE? So the COPE model provides families with disease education and care management strategies, along with comprehensive health screenings. The OT utilizes knowledge and skills to address care challenges that matter to the individual involved. The program is flexible and family-centric. A home evaluation is completed to identify ways to improve independence in the home, including fall risks and safety concerns. The goal of the program is to enhance the functioning of the person living with dementia while allowing the caregiver to become more autonomous. The program is designed to address the clinical symptoms of dementia, including behavioral and psychological symptoms, functional dependence, and caregiver distress. And it unfolds in 3 interrelated phases. So we're going to go over those together. First one, occupational therapist role. So occupational therapists are health and social care professionals who enable people to live life their way. I really like that definition. OTs assist with participation in activities of daily living while helping those suffering from dementia to remain as independent as possible. Phase 1. So in phase 1, assessments are done for the person living with dementia and the caregiver. The person living with dementia is assessed for cognitive function, physical function, fall risk, medication regime, and physical health. The caregiver is identified and assessed through communication strategies, readiness to change, and identified care challenges. The approach to assessment reflects a family-centric, strength-based treatment approach from which to tailor the program to the family's needs. So it's very client-specific and family-centric. The occupational therapist can provide help and training in undertaking daily activities such as bathing, dressing, eating, playing, and participating in a favorite hobby. The occupational therapist's role provides education and training to care partners on how to modify the environment to better meet the needs of the person with dementia. This may include providing guidance on lighting, noise levels, or furniture placement, as well as strategies for managing behavioral symptoms. The OT's role. The OT works with the client to find solutions to remove or minimize barriers, enabling optimal function. OTs consider the physical, cognitive, and affective dimensions of the client's occupational goals and performance, and have a unique focus on social, cultural, and physical aspects of the environment in terms of how it can either enhance or interfere with occupational engagement. So how do OTs support dementia patients? Well, we start with assessments and screening. This is how we identify deficits and strengths in that cognitive function. And then we're going to assess how these impact the ability to function in day-to-day life. So ADLs, mobility, social skills, leisure pursuits, and IADLs. Occupational therapists monitor the progress of the person with dementia and their care partner to ensure that interventions are being implemented and are effective in improving the quality of life and reducing behavioral symptoms. So how do occupational therapists support dementia patients? Well, they're going to identify interventions and strategies to minimize the functional impact of their dementia. For example, a couple ways that we do this is cueing. So cueing is motioning to the person, maybe we're going to take our shirt off. You're going to put your hand here. I'm going to motion for you to get up out of your chair. So kind of like charades, you're just using your body to motion to the person on what to do next. And then modifications of the environment. So this could be a room setup, signage, or a control station. So setting the room up for success. Using proper signage. So maybe our words aren't there, but we can understand a picture. So putting a picture of the toilet on the bathroom door. And then a control station is trying to get everything the person is going to need within reach. So their world has gotten a little bit smaller, and now we would like to facilitate a day-to-day control station for them to be able to read, access the TV, do any type of hobbies, and just be able to access everything from one place. Communication strategies. So when we're talking about this, it's between the care partner and the person living with dementia, and just ways to properly communicate, or when we can't communicate, how do we motion, verbalize, and show somebody what we mean. And then realistic goals for increased independence are a restorative approach, and this is what helps us with ADLs and mobility. So once we figure out ways to help a person be more independent, then they become restored and are able to approach those tasks a little bit better. So key challenges and opportunities. So occupational therapists interventions for caring for persons living with dementia and supporting their care partners face both challenges and opportunities. So here are some of the key challenges and opportunities. Challenges. So there is limited access to occupational therapy services. Many people with dementia and their care partner may not have access to occupational therapy services due to financial constraints, lack of availability in their area, or other barriers. Another thing is complexity of dementia care. Dementia care is complex and requires a multidisciplinary approach. Occupational therapists must work collaboratively with other healthcare professionals, such as physicians, nurses, and social workers, to ensure that the care provided is comprehensive and coordinated. Caregiver burnout. So caring for someone with dementia can be emotionally and physically exhausting, and caregivers may experience burnout. Occupational therapists must provide support and resources to help caregivers manage their own health and well-being. Now we're going to look at some opportunities. So person-centered care. The person-centered care model provides an opportunity for occupational therapists to tailor interventions to the unique needs and abilities of each person with dementia. This approach can improve quality of life and reduce behavioral symptoms. One such way is environmental modifications. So we can modify the physical environment to better meet the needs of the person. Caregiver support. Occupational therapists can provide education and training to the caregiver on how to manage behavioral symptoms of dementia, offer practical assistance, and facilitate caregiver support groups. This can help reduce caregiver burden and improve mental health outcomes. And then technology-based interventions. So advances in technology have created new opportunities for occupational therapists to provide remote interventions, such as telehealth, to people with dementia and their care partners who may not have access to traditional in-person services. So overall, occupational therapist interventions for caring for persons living with dementia and supporting their care partners facing challenges related to limited access to services, the complexity of dementia care, and the caregiver burnout. However, there are also opportunities to provide person-centered care, modify the environment, offer caregiver support, and use technology-based interventions to improve the quality of life to those affected by dementia. So this is kind of a little layout of what the COPE program looks like. So we've got phase 1 there, and that's the assessment phase. So that's the first 2 visits. Then in phase 2 is the implementation stage. So there we're going to be really going after specific care challenges to that family in sessions 3 through 8. With those challenges, we are going to brainstorm, we're going to come up with meaningful activities for the person, and we are going to create what are called COPE prescriptions. So these are kind of a map on how to address a certain challenge. And then in phase 3, we are going to be kind of looking at the future. So what are our future plans? What is working? What is not working? What do we need to modify? What do we need to plan for in the future? So as the disease progresses, what should we expect? So this is something I thought was really awesome and wanted to show you guys. My favorite part about this program is that the OTs complete 17 assessments in the first 2 visits. And I don't really know any other program where that is completed like this. So the ones that are administered to the caregiver are the background characteristics, health and well-being status, background characteristics of the caregiver, daily routines and activities, depression screen, perceived change index, assessment of physical function, assessment of executive function, assessment of behavioral and psychological symptoms, an activity inventory, a caregiver assessment of health problems, and then a medication review, which is completed by the PA or nurse. And then administered to the person with dementia. So we're going to test their mobility with the timed up and go. We're going to do a functional cognitive assessment. So that's usually the leather lacing, and a pain assessment, a skin integrity assessment, and a blood and urine sample. So those are all done by the PA or nurse, and are just going to give us some more information about the overall health of the person. And then things that we're going to be observing. So observations of comportment. So how a person greets me when I go to see them. Do they look me in the eyes? Can they speak their name? Do they extend their hand? Are they talking too much? Are they talking not enough? Readiness to change. So that would be the caregiver. And then checklists for observing strategies used by the caregiver. And then lastly, the evaluated home environment assessment. So we're going to make sure we don't have any fall risks and make sure that the home is conducive to both the family and the person living with dementia. So what is cognition? Cognition is a person's ability to learn new information, reason and problem solve, sustain focus and attention, recall items, and maintain short and long-term memory. So as I'm sure some of you know, with certain dementias, we stop losing the ability to learn new information. And then we have trouble with problem solving. And then our focus and our attention becomes shorter and shorter. And then that short-term memory starts to go. So there's kind of a trajectory of these things as they start to occur. And I think that some things are more prevalent than others and are more noticeable. It just depends on the person. So how do we screen this cognition? So the COPE program is going to use the functional cognitive assessment, so the ACLS-5, and that is the leather lacing. So that is going to give us an Allen cognitive level and let us know, essentially, it's an evidence-based assessment of functional cognition associated with cognitive disabilities model. So it's going to give us a rating. Then the ADM2 is an evidence-based standardized assessment of functional cognition developed within the framework of cognitive disabilities model. It includes 34 craft-based activity assessments, which provide opportunities for the individual to do new learning and problem solving in a meaningful activity that produces a useful, safe, and attractive end product. So here in Arizona, we're currently making visors and we're doing placemats, but there are 34 you can choose from. And then the sensory stimulation kit has items in it to assess all of your senses. So olfactory, visual, auditory, tactile functions, proprioceptive, and this is going to help us understand the facilitated adaptive responses. So sensory stimulation is often used for patients with IDD, so developmental delays. The program, so phase 2, implementation. So we did talk about how the occupational therapist gets to meet with the caregiver and the person living with dementia for up to 10 sessions, so unique. Those first 2 sessions are where we're going to get the most information. So we're going to put together an assessment after those first 2 sessions. And then we're going to address caregiver identified care challenges through the use of activity prescriptions. So non-pharmaceutical strategies. So what these look like: communication. So we're going to work on our communication strategies. Maybe talking less, maybe talking more, giving clearer instructions, watching how our body language is, not getting too upset. Cueing, we kind of talked about that earlier. So motioning, signaling, giving the person a little tactile cue as to what to do next. Behavioral management, so trying to identify triggers and ways to help those behaviors along. So what is causing the behavior and how can we not have this behavior happen? Self-management, so just giving that autonomy back as best possible. So creating areas of independence for that person. Identifying common behaviors and tracking those. Simplification of tasks, so just breaking it down, laying things out. So if you're doing cooking, perhaps putting all the ingredients out on the table. If you're getting dressed, maybe putting the clothes in order of how you put them on. Home safety protocols, so this could look like lighting, removing trip rugs, making sure the person doesn't fall out of the bed or doesn't run out of the house. So this could also look like a GPS tracker on the person. This could be alarm signals on the doors, maybe hiding the car keys, things like that. Future planning, so a plan B. So what happens to me if I'm the caregiver to my person living with dementia? So what does that look like? Do we have a plan B? And then local resources. So support groups, respite care, understanding hospice, really understanding all of the resources available to you and to helping you and your family. So skills training is something that uses problem solving and brainstorming to approach. It's a problem solving and brainstorming approach that identifies care strategies. And these include education. So phase 2, education. Education, caregiver education regarding safety risks and preserved capacity for the person living with dementia. So this can look like potential effects of medication, pain, constipation, dehydration, stress reduction techniques, and home and safety concerns or recommendations. So this is a current list of activity prescriptions. So what we're trying to do here is identify important, meaningful activities. So meaningful activities promote cognitive stimulation, emotional well-being, and a sense of purpose. Engaging in activities tailored to the individual interests and abilities can enhance overall functioning and quality of life. We want to identify individual interests and abilities. So conducting assessments to identify personal preferences, hobbies, past experiences, and functional capabilities. We want to gather information from participants, caregivers, and family members to develop a comprehensive understanding. And then creating the activity prescription, we'll do that based off the assessment findings, design personalized activity prescriptions that align with the person's interests, cognitive levels, and physical abilities. We want to consider factors such as sensory preferences, cultural backgrounds, and environmental stability. And then this is the second list of activity prescriptions. So implementing activity prescriptions, we want to communicate the activity prescription to support staff, ensuring they understand the objectives and strategies involved. We want to collaborate and support staff to determine the most appropriate timing, location, and resource needed for each activity, so the care partner or staff. Then we want to monitor and evaluate. So regularly assess the impact of the activity prescription on the individual's well-being, engagement, and functional abilities. We want to adjust the activity prescription as needed based on the participants' feedback, observations, and changes in abilities. So next, we're going to start looking at what session 3 looks like. So first 2 sessions were assessment. Session 3, we are now going to be implementing. So first, we're always going to start with a stress reduction technique. This is often deep breathing. Then we are going to discuss the use of activities and why these are meaningful and important. We will provide the family with the assessment so that they can review it and ask any questions. We will then dive into identifying one problem area. So start problem solving and brainstorming to identify strategies to address this problem. And then we will provide the caregiver with 1 to 2 strategies to practice. We may even role play these strategies with them just to make sure they feel confident. Then in visits about 4 through 8, we're going to continue checking in on that stress reduction and breathing techniques. We are going to continue to introduce co-prescriptions, so there'll be usually 3 total. And we're going to role play strategies and try to reinforce and validate the caregiver's techniques. We also want to complete the confidence rating, so how confident they are using the prescription. Then we'd like to continue identifying problem areas and continue using these prescriptions to come up with problem solving and brainstorming strategies to address the problems. So then we're going to kind of check in with the caregiver and modify the strategies if they are unable to use the prescription. And once again, always reinforce and validate the use of strategies. And then we're going to hit phase 3. So this is called generalizability. And the caregiver will meet with the occupational therapist alone to discuss ways to use learned strategies for other care challenges, as well as how to prepare for future decline and abilities due to disease progression. So what we're looking at here is problem solving, active learning. We want to be culturally relevant, and this is going to be tailored to the individual. And then we get into sessions 9 and 10. So this is the generalizability. So we still start with the stress reduction. Then we're going to review all of our COPE prescriptions and our activity prescriptions. We are going to look at our brainstorming activity worksheets, discuss what's working, what's not working, reinforce and validate strategies. We are going to review what other ways we could address these COPE prescriptions when cognitive abilities are going to change over time. We will model and problem solve and identify different ways that the caregiver can generate strategies alone. And we also try to work with them as much, just bouncing back ideas. But ideally, the goal is to empower the caregiver to start problem solving on their own. So this is a little model of kind of what COPE outcomes look like. So what we're seeing is the caregivers are less upset. They improved their caregiver well-being, they improved their caregiving confidence, and then we've reduced targeted problem areas. The person living with dementia is reducing physical dependence, is enhanced activity engagement, and is improving overall quality of life. So common signs of dementia in persons with intellectual disabilities. So occupational therapists working with patients experiencing the onset of both dementia and intellectual developmental disabilities need to consider several considerations to provide effective and holistic care for these individuals and their caregivers. These considerations include early identification and assessment. Early identification of cognitive decline and IDD is crucial for timely intervention. Occupational therapists should conduct comprehensive assessments to understand the individual's cognition, functional, and emotional capabilities and limitations. Early intervention can help slow the progression of dementia and enhance the quality of life for both the patient and the caregiver. We want to individualize our care plans. So due to the diverse nature of dementia and IDD, occupational therapists must create individualized care plans that cater to the specific needs and ability of each patient. These plans should focus on maximizing independence, engagement in meaningful activities, and addressing cognitive, motor, and emotional changes. Communication strategies. So communication may become challenging for individuals experiencing cognitive decline and IDD. OTs should implement effective communication strategies such as using simple language, visual aids, and incorporating familiar routines to facilitate effective communication and understanding. Sensory processing consideration. Individuals with IDD and dementia may have sensory processing difficulties. Occupational therapists should consider sensory preferences and aversions when designing interventions and create sensory-friendly environments to promote comfort and well-being. And then what you're seeing here on the screen is just signs of dementia in persons with IDD. So they're somewhat similar to the regular signs of dementia, except for you might have a development of seizures here. Everything else looks pretty much on point, yes. And then continuing on, so we're going to still go with IDD and dementia, and what we're talking about here is caregiver training and support. So caregivers play a crucial role in the well-being of individuals with dementia and IDD. OTs should provide caregivers with education, training, and resources to effectively manage and support their loved ones' needs. Offering support groups and counseling can help caregivers cope with the challenges of caring for someone with a dual diagnosis. We talked about environmental modifications in the past, but this can also help enhance the safety and promote independence for individuals with dementia and IDD. The OT should assess and make appropriate modifications to the home setting to reduce hazards and promote functional abilities. Adaptations for activities of daily living and instrumental activities of daily living. Dementia and IDD may impact the individual's ability to perform these tasks. OTs should develop an adaptive strategy, use assistive devices, and provide training to optimize the patient's independence in these essential activities. Cognitive stimulation and memory strategies. OTs can implement cognitive stimulation programs and memory strategies to slow cognitive decline and enhance cognitive functioning. These interventions may include memory aids, reminiscence therapy, or cognitive games and exercises. Palliative care consideration. In cases of advanced dementia and IDD, occupational therapists should collaborate with the interdisciplinary team to provide palliative care and support for both the patient and the caregiver. End-of-life planning and support for caregivers during this challenging time are essential. And then we want to be culturally sensitive with our care. So OTs should consider cultural beliefs, values, and practices when providing care to individuals with dementia and IDD and their caregivers. Understanding the cultural background can enhance the therapeutic relationship and improve outcomes. In summary, OTs working with patients experiencing the onset of dementia and IDD and their caregivers must approach care with individualization, sensitivity, and collaboration. By addressing these special considerations, OTs can play a crucial role in promoting the well-being and quality of life for those individuals and their caregivers throughout the course of their journey. With IDD, we need to adapt evidence for people. We need to look at non-pharmaceutical strategies. This is the frontline care. Many ways to many. One size does not fit all. There is no one magic pill. We want to consider the disease trajectory, etiology, life course, familial and living contexts, unmet needs, premorbid abilities and interests. And then we really want to look at principles for intervening. We want to look at the family, and we want to tailor all of our interventions around the preferences of that person. So in summary, the purposes and principles. The COPE program aims to support individuals with dementia by focusing on their unique needs, abilities, and environment. Principles include person-centered care, environmental modifications, meaningful activities, caregiver collaboration, and interdisciplinary teams. Benefits of the COPE program: enhance the well-being and quality of the life of the individual with dementia, improve engagement and socialization, reduce behavioral symptoms and agitation, and support the caregiver and family members in their roles. So how do you get involved? So I, through this process, became COPE certified. So that's right there on the screen for you. You can also complete a Dementia Friends training. I highly encourage that. You can join the new AOTA Dementia Practitioners Community of Practice. We've had about 3 meetings and it's pretty new. You do need to be a member of AOTA, but I highly suggest joining. There are 2 other techniques that are being used, evidence-based practice for dementia care. So one is Skills to Care and the other is TAP. So Skills to Care focuses on equipping caregivers with the necessary skills and knowledge to enhance their caregiving abilities. Through educational sessions and training modules, caregivers can gain practical techniques and strategies to effectively manage and communicate with individuals with dementia. This program aims to empower caregivers by building their confidence and helping them navigate the challenges associated with dementia care. On the other hand, the TAP program emphasizes the importance of therapeutic activities as a means of enhancing the overall well-being of both the caregiver and the individual with dementia. OTs work closely with caregivers to design personal activity plans that promote engagement, cognitive stimulation, and emotional connection. The program recognizes the therapeutic value of meaningful activities and seeks to improve the quality of life for both the caregiver and the person with dementia. Lastly, the COPE program takes a more holistic approach by focusing not only on the caregiver and the person with dementia, but also on their dynamic relationship. This program acknowledges the emotional toll that caregiving can have on both parties and offers strategies to manage stress, improve communication, and foster a positive caregiving environment. OTs play a vital role in facilitating these interventions, which ultimately aim to strengthen the caregiver person with dementia bond and promote overall well-being. In summary, while Skills to Care, TAP, and COPE programs share the primary objective of supporting caregivers and the persons living with dementia, they differ in specific approaches. Skills to Care emphasizes caregiver education. TAP highlights therapeutic activities, and the COPE program prioritizes relationship dynamics. These programs collectively contribute to the individual role of occupational therapists in improving the lives of caregivers and individuals with dementia. And then following Skills to Care and TAP, we do have the dementia squad. So there is an Arizona dementia squad you can join. We also have our 3-day clubs at Oakwood Creative Care. And then below that is Benavia. So that one is in Surprise, whereas the other ones are in Mesa. And then we do have a couple resources here. So the top two are, the first one is the book that I got the dementia definition from. So that is the one by Jerry Hall and Dr. Burke, and it is a free resource through Barrows. The second one is a book from Dr. Gitlin, and that book is really helpful. It's an easier read for the client, and it really gets down to certain behaviors and problems that might need to be addressed sooner rather than later. We have our Oakwood Creative Care website here. So please go on there and check us out. You can check out the COPE program, the mission and vision. We do have the Dementia Society, and then there is the COPE program videos that you can look at on drugs. And then I do have some resources here for you as well. So thank you so much for sticking it out with me, especially with my word jumbling. I really appreciate it, and I hope you enjoyed this PowerPoint presentation. Thank you so much.